Hi, welcome. I think I'm going to start. My name is Deka Muse. I am part of the engagement team. We are part of the Improving Me series, which is a women and children service partnership aiming at improving the experiences of women and children across Cheshire and Merseyside. The main goals of the partnership is to empower women to take control in decisions about the care they receive, to better meet their needs and preferences. We engage in decision making about the services that are offered by working together through collaboration, cooperation, and co-production in order to deliver safe, more personalized care for all women and every baby, to improve income and reduce inequalities. The webinar aim is to provide the information and the resources across Cheshire and Merseyside, discussing key health priorities to improve women's health. With me today is the engagement team, Benin and Danny. Can you introduce yourselves?
Hi, my name is Benin, Community Engagement Lead, Cheshire and Merseyside Women's and Children's Service, Improving Me team.
Hi, I'm Danny. I'm also a Community Engagement Lead here at the LMS.
Thank you, ladies. And we have here our co-chair, Mary McCollin. Hi, Mary.
Hi, good afternoon, everyone. My name is Mary McCauley. I'm a consultant obstetrician at the Liverpool Women's Hospital. And I've also worked for about 6 years at the Liverpool School of Tropical Medicine, conducting research to improve women's health in low-resource countries.
Thank you, Mary. Today our presenters are Cara Williams and Rahima Farah, and we have Louise Worthington. So I'll hand back to Mary, please.
Brilliant. So good afternoon, everyone, and thank you so much for joining. I'm so excited to be part of this webinar and just delighted to see so many people interested in this really important topic. Today we're going to talk about females' genital mutilation or female circumcision. We've got three really exciting presenters. Dr. Cara Williams, she's a consultant gynecologist at the Women's Hospital. Rahima Farah is going to give us some experience of what she's been involved with at the Women's Hospital and also the patient perspective. And then we have Louise Worthington, who's going to talk about safeguarding at school. We have 15 minutes at the end of the after the presentations to really have some questions and answers. And the aim of the webinar is really to increase awareness so that we know what the community feel and how we can, as Dika mentioned, how can we really improve care for women who have had this condition, and how can we improve care in the future for other patients going forward. So please do post some questions, please do link some comments, anything that you'd like to add. We look forward to engaging after the presentations. And so I'll hand over to Dr. Cara Williams, consultant gynecologist at the Liverpool Women's Hospital. Thank you, Cara.
Brilliant, thank you, Mary, and thank you to everyone for inviting me to speak today. Okay, can you all see the screen now? Yep. Excellent. Okay, so I'm going to talk about what FGM is, the definition of the 4 types of FGM, the long-term complications that women can have from FGM, both obstetric and gynecological. I'm going to talk about de-infibulation, which is the procedure to open up the vagina following FGM. And then I'm going to talk about a bit of the legal aspects, so mandatory recording, which is filling out the enhanced data set that is required, and the mandatory reporting, which is involving girls under the age of 18 when we see that there's evidence of FGM. So FGM involves the partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. The practice has no health benefits for girls and women, and it's a violation of the human rights of girls and women, and this is taken directly from the World Health Organization. More than 200 women and girls alive today have been subjected to FGM across about 30 countries within Africa, the Middle East and Asia. It's mainly carried out between the ages of birth and 15, but there are cases that happen over the age of 15. The WHO is opposed to all forms of FGM and it's opposed to the medicalisation of FGM. So there are 4 types. Type 1 is where the woman has either partial or total removal of the clitoris, including either the glans and or the clitoral hood. Type 2 is partial or total removal of the clitoris and or the labia minora or majora. With type 3, it's also called infibulation, and this is where the vaginal opening is narrowed one way or another. So sometimes the clitoris and or labia may be removed first and then the edges stitched together, or sometimes it's the outer labia which is stitched together, but actually nothing is removed inside. Type 4 is anything else other than those that would fit into type 1, 2 or 3. So any harmful procedure. So this may include cutting, picking, piercing, incising, or it even includes inserting caustic substances into the vagina, such as potassium permanganate. There are numerous short-term and long-term complications. Genital scarring as a result of the FGM. This can be unsightly, it can be painful, they can get keloid scarring, and they can get quite large inclusion cysts which form over the scar tissue. They may have urinary tract complications, so the urinary flow might be poor because of the obstruction on the outside. They may get backflow, and then that can lead to recurrent urinary tract infections. When the vaginal opening is smaller or more narrow, that can cause pain with sex, and they may not be able to have sex because the opening is too small. The nerve fibres run along the surface of the labia and on the clitoris, and if that area has been removed, then they'll have reduced sensation and potentially anorgasmia. They may have loss of libido and poorer long-term sexual satisfaction. Genital infections such as bacterial vaginosis and other infections are more common. Menstrual difficulties, including painful periods and obstructed menstruation if there's a complete blockage to menstrual flow. That can then lead to infertility, or the infertility may be as a result of them not being able to have full penetrative intercourse. The psychological effects include flashbacks and anxiety and post-traumatic stress, and these shouldn't be underestimated. From a pregnancy point of view, they may have a difficult, prolonged delivery if there's obstruction to the baby coming out. They may bleed more, or they may require a cesarean section because of the obstruction. This is a picture of an inclusion cyst, which you do see relatively frequently. This is where the clitoris has been removed and a cyst has formed underneath the scar tissue. So the catheter is going into the bladder, so there's a small vaginal opening here, which you can see if you lift up the inclusion cyst. So you make an elliptical incision over the top of the skin and remove the cyst, and then close the skin back together, which you can see here, and then there's the vaginal opening. So de-infibulation is where we open up the vagina, and this would be performed to enable normal sexual intercourse, to allow them to have smears and normal sexual health screening, and to allow delivery of the baby. We ideally like to do this outside of pregnancy, and we do have a self-referral form on the Liverpool Women's Internet for women around Cheshire and Merseyside to self-refer in if they've been subjected to FGM and if they've got complications or if they want to have de-infibulation. This means that they don't need to go via their GP, and everything can be kept confidential if they want that. If the woman is pregnant, then we ideally perform it in the antenatal period, although it can be done intrapartum, but it will depend on the expertise of the clinicians looking after them in labour, as they would need an anterior episiotomy, which isn't routinely done. In pregnant women, we normally advise the mid-trimester. The reason for this is if it's done in the first trimester and then the patient goes on to have a miscarriage, it may be associated with the de-infibulation, but it won't have been the cause of it. But normally we like to get them through to the mid-trimester first. And then it also gives enough time for healing prior to their delivery. So we offered the women the de-infibulation under local anaesthetic or general anaesthetic, and the vast majority are choose to have it under local anaesthetic, and it is really well tolerated, with some good support in the clinic for the patient and interpreters if required. So this is taken from the Royal College of Obstetricians and Gynecologists, and it's a really good pictogram of how de-infibulation is performed. So here you can see the narrow vaginal introitus, and the tissue is joined together at the top. So you insert some local anaesthetic into the skin. Then you make a vertical incision, and you make your incision until the urethra is visible. If you go any further, you're not actually opening any more vaginal space, you're just going into tissue. So you open it up until you can see the urethral meatus, and the vagina is all below, so you then know that you've opened the full size of the vagina. And then it just has some interrupted sutures on both sides just to close the skin edges together and stop any bleeding. So then moving on to the FGM Enhanced Dataset. So this is all about mandatory recording of data. So this is different from mandatory reporting. So the recording is basically all NHS acute trusts, mental health trusts and general practices have to submit data to NHS Digital. This is collected every quarter, and it provides all the information about all the women we see within the trust who've come with FGM. And this is in order to improve how the NHS can support women with FGM, to be able to plan local services and help to stop FGM occurring in local communities. It does contain personal confidential data, including their name, date of birth, NHS number and their country of origin. And it's really important that we inform the patients that this information is being used, but it's only being used so that that data can be validated and ensure that it's good quality, to make sure that you don't have repetition, because if two clinicians put the same details through, not realising the other person has, it will skew the data. So this information does need to go through to make that data validated, but it only goes to NHS Digital and it doesn't go anywhere else. The FGM IS is a national IT system which was launched in 2014, and this is a database which contains information about all girls who have a family history of FGM and are therefore potentially at risk. Mandatory reporting is a mandatory duty to report to the police any girl under the age of 18 who has FGM. And this was introduced in October 2015 as an amendment to the FGM Act from 2003. So regulated health and social care professionals and teachers are required to report any case of FGM in a girl under the age of 18 to the police. This is a GMC requirement, and you can be sanctioned for not reporting by your regulatory authority if it's found that it hasn't been reported. This does include historic cases, so if you see a 17-year-old and they had it when they were 2 in a different country, it still needs to be reported because they're under 18 now. It includes all types of FGM, including type 4, so even the piercing, pricking, cutting, etc. But this mandatory reporting is just for England and Wales, so Scotland have their own rules. For the reporting process, if you identify someone under the age of 18 with FGM, you're advised to call the police as soon as possible, and at least by close of play on the next working day. You call the police line, which is 101. You'll explain the situation to the police, and they will then give you an incident number. You then need to inform the safeguarding term and social services. But it's important you phone the police first because the social services will want the incident number that the police have given you. So it's always ideal to do it in that order. It's really important to inform the parents and the carers that you're doing it. It doesn't necessarily mean that anything will happen to the parents if this was done in their own country before they move to the UK. But it is important to let them know what's going on so they don't just get a call from social services without being aware that that might happen. And it's important to document all your findings of the examination, your conversation with the parents and your police and safeguarding teams. So this is taken from the government website and basically say to share FGM, then it's your mandatory duty to report that to the police on 101. If you suspect FGM has been carried out but you haven't yet examined the girl, or you consider a girl to be at risk of FGM, then you speak to your local safeguarding teams and follow their processes. You don't phone the police at this stage, you only phone them if it's been identified and confirmed. There's obviously with the type 4 FGM, that includes picking and piercing, and then there's the debate as to whether genital piercing, genital tattoos and female genital cosmetic surgery should be classified as FGM. In terms of the mandatory reporting side of things, the Home Office's stance on that is if you see someone with any of these under the age of 18, you should make a report. For the purpose of the mandatory reporting duty, you're not required to be satisfied that a criminal offence has been committed. That's up to the police to decide whether that's the case. But their advice is if you do see this, you are to make a report to them. The way that the genital cosmetic surgery and genital piercing, the way that they get round the fact that they don't feel people who do these procedures can get around it being FGM is that in terms of the FGM Act, Section 1 of the FGM Act states that it's a criminal offence to excise, infibulate or otherwise mutilate the whole or any part of a girl's labia, majora, minora or clitoris, but no offence is committed by a proved person who performs a surgical operation on a girl which is necessary for her physical or mental health. And most people who perform female genital cosmetic surgery will argue that they're doing it for that girl's mental health. And that's how they would probably bypass it being FGM. But in terms of for female genital cosmetic surgery, it's not advised under the age of 18. It's not available on the NHS, even if they're over 18, because it's thought to be a cosmetic procedure and there are no medical indications for performing it. And therefore, it is advised if you see someone with that, you do report them to the police. So the other amendments to the FGM Act from 2003 came in 2015. So the mandatory reporting was one which we've discussed. The other one was, which was really important, was the offence of failing to protect a girl from the risk of FGM. So prior to 2015, if a girl was sent back home for a long summer holiday and the parents stayed in this country, and while the girl was over in that home country and she had FGM performed by the local community and the parents weren't aware of it, then the parents wouldn't be held accountable for that. But if it were to happen now, those parents have failed to protect their child, and therefore they could be criminalised for that. There's also extraterritorial jurisdiction over offences of FGM which have been committed abroad by either UK nationals or those who are living either permanently or temporarily in the UK. There's also lifelong anonymity for victims of FGM, which is great. And there are FGM protection orders which can be used for girls under the age of 18 who are at risk of FGM. And this is linked to their passports, so they can be protected from being made to go abroad to have it done. Just a quick look at the potential sentences that people can get for performing FGM. The actual performing of the FGM is up to 14 years plus a very hefty fine. Failing to protect your child, even if you've not been the person performing it or been aware of it, is up to 7 years plus a large fine. And a breach of the protection order is up to 5 years plus a fine. So in summary, that's a very quick overview of FGM. So in summary, FGM has no health benefits and it's a violation of the human rights of girls and women. De-infibulation is ideally recommended prior to pregnancy, but if they are pregnant, we would ideally do it in the second trimester. The FGM Enhanced Dataset is the recording of data to help support women with FGM. The FGM IS is the IT system database for girls who are at risk of FGM due to a family history. And it's our mandatory duty to report any girl under the age of 18 with evidence of FGM to the police. And that's it. Thank you very much.
Is Rahima here?
Hi everyone. Well, Cara, I think you covered everything there. My name's Rahima. I'm an advocacy worker and I work for Merseyside. I'm here today just to give you basically a patient perspective of the work that we used to do in the women's. I used to work in the Link Clinic alongside the consultants. So my main role was basically like finding out if the client had actually suffered from FGM and what type they suffered from, work with the medical consultants, and also to educate them about the law. So for instance, if they were a patient who had FGM and they were having a daughter, then obviously I've talked to them about that if you couldn't practice FGM on your child in the future. I'd listen and support the client. And also sometimes it would require like going to doing a home visit, because for certain cultures like the Sudanese community, they tend to, when they have the FGM, the de-infibulation, they tend to actually go back into their own country to get sewn back up again. So it's about educating them to say, no, you can't do that and it's against the law. And that used to require doing home visits and building up that connection and support with the client. Like, you know, I'm not a trained counsellor, but I found that within my role, I had to be a good listener and speak to them, keep focused, and support them, because sometimes they were scared. Because obviously they know they had FGM in the past and a lot of them had very traumatic experiences. So we just go through it, only obviously if they were happy with it, and support them. And I also maintained strict confidentiality, which is really important to do in this sensitive subject. Also, A lot of them had a lack of trust, you know, fear of doctors, midwives. Everyone had a horror story to tell me, whether it was back home or a family member. So we would discuss that. Some of the women were scared of getting pregnant, or even having, you know, a section, you know, having, you know, going through having a reversal, to be scared of the operation. So we used to go through that and talk about trauma and things like that. Another part of my role was community links, working with the communities, signposting them to different agencies that could support them. I worked closely with the mosque, and they'd, you know, signpost me to some of the clients, and talk about how to get referred into the clinic. For those women who were not pregnant, as Cara was saying, there's 2 different clinics that were run. One for the women who were pregnant and ones who wanted to have the operation but who wasn't pregnant. So I'd signpost them to the right one. So the clients, they'd come into the link clinic, obviously with a book, they'd meet the consultant, and they'd discuss the procedure and how they were feeling. And if the client required more support, I'd support the client, and then they'd sign the paperwork to agree the operation. Some of them clients I actually supported and went through to the operation with them, and seen it right through to the end, it was good because they had that continuity of support, which the Liverpool Women's offered, and they don't offer that everywhere. Also, about the Act, which you discussed, Cara, about the Female Act 2003, if the child was to be taken abroad, they'd still have the same, you know, not a lot of people were aware about that. So we used to talk to them about that, educate them on the law. So in the community, a lot of them the Somali community, which I used to work closely with, a lot of them were very uneducated. A lot of them had like false beliefs. So we did a lot of education, a lot of training, a lot of signposting, and just discussing, you know, the complications. Just like, you know, a lot of the clients that came, just having that reassurance and comfort, and to be able to open up and speak to me. It was really nice to offer that service within the women's, to be able to speak along and speak with them and understand and tell them about cases that have happened and how that I can engage with them. So yeah, that's just a summary of what I used to do within the women's. Right now, obviously it's COVID-19, so we don't get to, we're not actually visible in the women's, but I get a lot of referrals within the community, and I signpost them over to the Women's Hospital. And I'm just looking forward to coming back and being part of the team again. So I'm going to stay on to the end to answer any questions if you'd like to ask me.
Fantastic, and we're looking forward to having you back in the
Oh, can't wait.
Yeah, the sooner the better.
Oh, thank you.
I've got some questions for you as well at the end. Looking forward to discussing. But hand over to our 3rd presenter for the session this afternoon, Louise Worthington, who's going to tell us a little bit about safeguarding in schools.
Hi everybody, can you hear me okay? Because my internet is not very good here.
Yeah, thanks Louise.
Thank you. My name's Louise Worthington, and I'm presenting today as the designated safeguarding lead in Smithdown Primary School. So for those of you who don't know where we are, we're kind of right next door to the Women's Hospital, really. We have got a very, very diverse community, and I am just one of a team of safeguarding leads, if you like, in the school. So obviously the head teacher, Mr. Horn, has got overall responsibility, but because he wears many hats on a day-to-day basis, I'm the safeguarding lead, and I've also got like a team around me as well. With regards to specifically FGM, myself and the head teacher, as being designated safeguarding lead and having overall responsibility for safeguarding in the school, we have to attend a half-day briefing every year, and that's not optional. We have to go on that. And then when we complete an audit the year after, we have to put the dates and then who it was delivered by. FGM is always on the agenda. And then it is our responsibility then as a school to feed that back to our staff through either inset or twilight meetings or staff training. So all our staff receive basic safeguarding training, which covers, you know, a whistle-stop tour, if you like, of safeguarding. And then throughout the year, we will have individual focuses. So, for example, we might have radicalisation and prevent one month, and then the next month it will be FGM. And obviously that is important to do that annually because of new staff, just to keep it in everyone's minds, really. We have a staff notice board, a safeguarding notice board in the staff room, and it has information about FGM on there. As Cara said before, you know, our procedures for if we suspect FGM, really, we're trained as, like, you know, the one chance rule, and don't say what if I'm wrong, it's what if I'm right. And once that opportunity is gone, it's gone. And it's really, I feel, our responsibility as safeguarding leaders within the school to educate the staff and the learner support assistants, because people have a whole wealth of different backgrounds and have grown up in a whole host of different places, and we have to eradicate the opinion of, oh well, it wouldn't happen to one of our children, or no, not here. And it's like, no, yes, it could, and it, you know, it could, and it has happened here. So as Cara said before, you know, if we saw indicators that FGM has happened or may, you know, an extended holiday, something that the children maybe had to keep a secret, that we told they couldn't tell anybody. Sometimes secondary schools actually get in touch with us and say, we're worried about this child, you've got siblings, you know, could you get voice of the child? And, you know, so we would call the police, we'd follow our procedures, call the police, get an incident number, refer to social services, and we'd also ensure that we then spoke to parents with an interpreter, so there was no miscommunication. I receive a safeguarding matters monthly update from the local authority, and that also keeps me on top of any changes in policy, any current issues around FGM that I might not have been aware of, which I then filter onto staff. And really, it's about our awareness and the staff knowledge, and it could and has happened here, you know, and those opportunities, the indicators, what are they? And obviously we've got an internal monitoring system. So if somebody puts something on about a child, maybe in nursery, the safeguarding team will all see that. So even if the nursery teacher doesn't particularly make a link, then one of the safeguarding team should make that link to make sure that there's no missed chances. And that's it, really. That's my role within the school, and anything that we can do to increase our knowledge or you know, work with the community, we're more than willing, obviously, to do that.
Brilliant. Thanks, Louise. Lovely to hear what's going on there. So I'll just hand back over to Dika, who's going to lead on the question and answer session.
Thank you, Mary. Thank you for the presenters. Very interesting and insightful indeed. I'm going to hand over to Danny to check whether there are any questions in the chat box.
Okay, so we've got one from Cara's presentation here is, who has access to the FGM data collected in a hospital, and is there a potential for breach and exposure of the patient's information?
Okay, so we submit, well, the safeguarding team collate all of the data and submit that to NHS Digital. NHS Digital then, once the data's been validated, in their final report, they don't include any of the patient-specific confidential data. So the final FGM report that NHS Digital do doesn't contain any of that information. There is some information on the NHS website for patients. So if they're not happy about their data being used, they can, there is an email address that they can follow to state that they don't want their information being used, and it talks about the safety of the data and what happens with it, and how it's, you know, not used in the final report. So patients can be signposted to that website for more information.
Fabulous, thank you very much. And so it was kind of a comment and a question around the mutilations that are allowed for a girl's mental health, and they were just wondering how is that, and how would mutilation help relief of any mental health problems? Yeah,
so I personally don't agree with female genital cosmetic surgery, but there are clinicians, surgeons who do perform it. It isn't illegal, and I think, you know, there's no medical indication to do female genital cosmetic surgery, labiaplasty, clitoral reduction, you know, unless there's something pathological, which is very rare. But I think if you were to say that female genital cosmetic surgery was FGM, the way they'd get around that, the plastic surgeons or gynecologists who are doing that procedure would state they're doing it for the patient's mental health, which means it's not illegal in the FGM law. Girls will often, and women will come to the clinic stating that their labia are revolting and disgusting, and they can't cope with how they look, and it stops them going to the beach, it stops them having a boyfriend. There's all sorts of different things that they say about not liking their labia, and so the surgeons who do it will argue that they're doing it for their mental health. I don't agree with it, but that's how it is, unfortunately.
Thank you very much. And one of the things around the Liverpool Women's Hospital is how widely known is it that women can access Liverpool Women's if they've had FGM, and what proportion of women from out of Liverpool access the service? And then if that's quite a low number, do we need to have more comms around it going out to like the MVPs and other kind of family forums?
Yeah, so I set up the self-referral form about 2. One of them came from Manchester. So I don't know how she'd found out. I think she just did a Google search and happened to find it. So I did contact our communications team recently, and they've done a campaign on Twitter and Facebook via the Liverpool Women's Hospital Facebook and Twitter pages. But if anyone has any other ideas of how we can disseminate that information more widely across Cheshire and Merseyside and further, then please feel free to let me know, because I'm more than happy for it to be, you know, be advertised further, because we don't get many referrals.
Fabulous, thank you very much. And then there's just 2 more. So for Rahima, this one's for you. Do you speak with the imams to explain communities about the rulings of FGM in Islam?
To be honest, we did used to do a lot of engagement with the imams. They're very up to date, and they used to do like presentations around it. But recently, obviously with the COVID-19, we've not done as much engagement within the communities, but we'll be looking to do that once everything's open. But yeah, they're very knowledgeable around that.
Oh, thank you very much. And a last question in the chat box before we go to some of the source ones from the communities. Is it true that the women who have had FGM will never enjoy sexual intercourse?
So there's evidence that women can have reduced enjoyment with sexual intercourse, but I don't think you could say that they never enjoy sexual intercourse. It will obviously depend on the type of FGM they've had, any, and there's lots of reasons why someone may find sexual intercourse difficult. But I don't think we could say they will never enjoy it, but there is definitely good evidence that they have reduced sexual enjoyment and function.
And different women, have different experiences, isn't that right, Cara?
Yeah.
Yeah. And there's different types of FGM as well, with the different types, each person has different experiences.
Brilliant. Cara, do you mind if I ask a few quick questions?
Yeah, sure.
So what type of, how many people would you see on a monthly basis, for example, who require or who are keen to have defibrillation?
So the majority of referrals that I get for de-infibulation come from the antenatal clinic. Those who are not pregnant, not very many at all, very few. So maybe no more than a handful a year.
And do you think, how do people, what's the journey like for people who go through this procedure? And have you had any patients that have refused the procedure?
I've had a few pregnant women who haven't wanted to have it done. They've just said, I'll wait until labour and see what happens. I've also seen women who end up having elective cesareans because they're so traumatised by it, they can't have vaginal examinations or anything, or want to go through labour, so have elective sections. I think it will vary depending on the type of FGM they've had, what age they were when they had it, whether any anaesthetic was used at the time, whether there was any force used to pin them down, anything like that. So I think, their experiences will vary so much that, some will say, I'm aware that I had it when I was a baby, age 1, but I don't have any memory of that. So, that they're less traumatized by someone who was, say, 10 or 11 and has very vivid memories of being tied down or held down by family members while it was done. So I think it depends, but the vast majority tolerate it really well under local anaesthetic. The initial local anaesthetic going in is uncomfortable, but once you've given them really good pain relief, they don't really feel anymore, so they're happy. And I think as long as you've got someone good in clinic with you who's talking to them while you're doing it all and keeping them occupied, I think that's really helpful. And
thanks, Cara. So I do appreciate that there is a mental, you talked about the trauma associated with this procedure. Do you know that within the Liverpool Women's Hospital, is there access to psychosexual therapy, or do you know of any midwives who are trained in this area, or nurses or midwives who are trained specifically to counsel women who have had this procedure, especially the more severe types?
So we've got 2 psychosexual counsellors at the Women's who we can refer to. They're not specifically for FGM, but it's psychosexual counselling in general. But unfortunately, we don't have any specific psychological support for these women, which is a shame. It would be great if we could.
Something to consider. We could work on to improve the service. Rahima, can I ask a few quick questions?
Yeah, let's go.
So whenever I see patients in the Link Clinic, part of it is to ask patients their kind of perspective of the practice. What do they think about the practice? Do they support this practice going forward? And predominantly, most people say no, they don't support the practice of FGM. So what's your feeling within the community, or within the regional, national, setting? So do communities? My impression would be that most people don't support this practice going forward. What's your understanding?
To be honest, I've worked in, when I first came into my role 19 years ago, it was as the FGM link worker. So I did a lot of gauging with the communities. Then back in them days, there was different mixed messages, but it's totally changed now. Everyone is totally against it within the communities. They're very aware of the law that exists, and we get such. I'm a mother of 4 daughters, and this new generation, they can see, if someone's gone through FGM themselves, they don't want to do it to the children, and having the law behind them gives them that extra, you know, like I can't do it because of the law. So yeah, we have right now people are totally against FGM, and in certain countries now worldwide, you know, there's laws where you know certain places where they don't practice FGM, which is really, really good.
Fantastic. I think, yeah, definitely the law change in the UK has definitely given people a bit more kind of confidence to implement the changes. I know in some countries, even if FGM is illegal by law, it's difficult to implement the guidelines and the policies, and you know the practice can still continue. Louise, can I ask a quick question?
Could we first ask, Benin has been having her hand up for a while now.
Hi, Benin.
Hi. Just to comment on the question came in about the Islamic scholar about FGM. I've been research while I was doing my research, and I've asked a couple of Islamic scholars about FGM, and I'm a Muslim and I read the book, and I have not seen anything in the Quran that approve FGM. And Islamic scholar, they all said it's not part of religion and it's nothing to do with the religion. So it's just part of the culture, and it used to be practiced earlier in perform in Egypt when Pharaoh time, and this how it started FGM. If it is something to do with Islam, would have been practiced in Saudi Arabia.
Yeah. Can I also add on to that, Benin, as well? But it's nice to be able to, for me, if I had a client in Liverpool, it was nice to be able to refer them to the actual imam for them to tell them, you know, the local imam to speak to them and say, no, this is forbidden. You know, someone that they're familiar with, someone that they see on a regular basis. So it's nice to have that communication with the actual imam from your, because, you know, we know that it's not allowed in Islam, but it's still practiced. So yeah. Thank you.
And it's practiced in Christian and Jewish communities as well as Muslims, so it spans all religions.
Yeah.
Yeah, and in the Link Clinic, I'm starting to see lots of more patients coming through from Middle East, actually from Iraq and Iran with the FGM, but most of the FGM that's reported on examination is the milder versions, or FGM1 or FGM4. Can anyone comment, or any knowledge of, or any links with the community within the Liverpool from Iraq or Iran?
Most of the findings, they mainly are based in African countries, what I've seen, you know, but I rarely see something in, you know, Asian countries. That's what we found out. Yes, Devender?
Yeah, that was one of my questions. It was to ask in Kara's presentation, it's widely said that it's across Africa, Middle East and Asia. And I wondered, actually, would some of the kind of Asian countries that practice it, would women from there be under the radar a little bit, because we're also aware of the kind of countries in Africa and the Middle East that, you know, may or may not practice it. And I wondered which countries in Asia.
Yeah, I think you're right, Devinder. There probably is that risk that, you know, we focus on Africa and the Middle East and they do get forgotten a little bit. As far as I'm aware, the most common places are Malaysia and Indonesia, but also Thailand. Malaysia tends to be more of the type 4, so more of just picking or piercing, so may not necessarily have any scars there. But I think that's why it's so important that when women are booked in their initial antenatal clinic, that every woman is asked if they've ever had FGM, so that we don't miss any.
Yeah, I think that's a really important point, especially you know, in the Link Clinic. Perhaps it's an unconscious bias that the booking midwives don't ask all patients, or patients, you know, from different geographical locations with regards to FGM. They may be aware of common areas, but not necessarily Malaysia and Indonesia, which we do know is common. But that's a great point, and we can definitely look into that.
Yeah, I mean, I'm Malaysian and I didn't know.
Can I ask Louise a question about, is Louise still on the call?
I am.
Hi, Louise. Have you had to deal with any cases of any children at risk? Do you know what kind of numbers are we? Do you know anything about the numbers in the region or nationally about children at risk, or have had this?
I don't know about the region or nationally, but we've had sort of different circumstances. So we know of a family whose the authorities informed us when the little girl joined us in reception that she'd actually already had it done. I don't mean it's already been dealt with before us, but authorities had already sort of, you know, so we're just mindful of her health really, and mum knows that she can always come to us and we can make a school health referral, or we'll find out somebody, you know, if little girl is struggling. We did make a referral actually. Well, when I say we, I was off on maternity leave, and we did make a referral, and it was quite difficult, and it was unfounded in the end. Actually, it was taken no further. But at the end of the day, the family did turn around to us and said, you know, we understand that we understand how you reached this point, and through different things that were said and different actions and behaviours. We understand. We know you've got your duty of care. We know you want to safeguard the children, and you know the children remained in the school, and relationships were rebuilt. But unfortunately, we have to. But I'd say, you know, it's quite rare. Maybe even one per academic year, if that, to be honest.
Can I just add to that? So I work at Alder Hey as well, and I do joint examinations with the paediatricians for cases that are suspected of having FGM. And we probably do, I don't know, 6 a year maybe. And the vast majority are girls who've recently moved to the UK. And when they've had their initial assessment with the paediatricians, it's come about that they've had FGM when they were younger in their other country. And so we do an examination just to make sure that there's nothing going on that's going to cause them any complications in the future. But we also get involved if there's any cases like you've just described, Louise. So we did have one recently where there were 2 siblings. I think there was 2 of them, 2 girls who were going off to Africa for a wedding. And there were certain things in the history that didn't quite add up. There was something, you know, it's so in the end, I think, I don't know whether it is the same case, but a judge ruled that the children could only go to Africa to this wedding if they'd had an examination by us before they went and when they came back. So we did both of those examinations on the girls, and there was no evidence of FGM before they went or when they came back. Now, whether we potentially stopped anything from happening when they were away, we will never know. And the parents weren't best pleased with having it done, but I think they could understand that everyone was just looking after the girls' safety.
Yes, Rukaya has a hand up.
Yeah, hello. Just as a comment about 2 aspects, the community awareness of FGM and also what the Islamic scholars say about. The community awareness, I agree with Rahima, is widely frowned upon now, and not only in the community in UK, but also in Somali community. I'll talk about back in Africa. I've seen in my own eyes few people who had to call upon their families and say, please stop, do not do that to the girls. So it's not only happening in the UK, but it's kind of like really widespread now. And then the second one about the imams, I asked that because recently I have seen with my own eyes and ears a sheikh that is talking about saying, well, we have to do it in Islamically, but you don't have to do type 1 or type 2, but the type 4 backing, just you have to do minimum of backing. So that's why I was thinking in my head, is there some scholars who still believe that and a breach to the community, and is that maybe that is the reason why in Indonesia and in Malaysia you have seen type 4, the backing. and because they are Islamic countries. So still there are some beliefs that say, no, we don't have to listen. You don't have to totally damage, but you have to do minimum of the backing. So it's and with some people, they will get so confused that they wouldn't know what to do. So that's my comment.
Absolutely, it's got nothing to do with Islam, Ruqayya. You know the book, you read the book. Have you seen any chapter in the book or any verse saying that they have to circumcise women?
No,
we know
not
about
all.
men.
No,
we
no,
know
not
about
at all.
men.
I understand that, and it's now like majority of the scholars are preaching and saying, no, that is a pharaoh, that is a something Pharaoh done, and it's nothing to do with Islam. But still there are some scholars who tell people, and then if they tell some people who are not really knowledgeable and they don't listen other than their sheikh, then they will hear that and they will say, well, we have to do this, otherwise we will get into trouble. So still there are few people, we still have to go and communicate even more. That's what I'm saying. Because I have heard the sheikh, he was preaching, and I listened to him on YouTube, and I was thinking, what's happening? So there are still people who are preaching.
Sorry, I don't call them scholars. Some people who I don't agree with them, and I'm not going to call them scholars. I've got some question actually came in from the audience. Very important question. I had an FGM performed, and I am pregnant now. Do I have to undergo a C-section?
No.
Go on, Mary. You can answer that one.
So at the Liverpool Women's Hospital at the antenatal clinic, then there will be an appointment for the patient to have a full assessment where we go through your history of what's happened, and we offer an examination so that we can determine what type of FGM the patient has had performed. So most patients that we see are type 1 and type 2, which are the milder forms, and type 3 is the type of FGM where we would offer the surgery with the help of Cara to open up the scar tissue. So definitely not, it wouldn't be recommended to have an elective cesarean section because of the operative risks involved in that, but we would treat every individual, you know, every case is an individual case, and we would take into account patient choice and patient experience, and we would really try our best to take as much time with the patient to understand the reasons for whether they would like to request a cesarean section to avoid any further vaginal trauma. And we would definitely try and make an individualised care plan or birth plan for the patient to give as much reassurance about what would happen during the pregnancy and especially the childbirth.
I have lots of questions. I'm not sure if we have more time, but also there is an important question. Is it true, or is it a myth that female who have undergone FGM tend to give more pleasure to their men than those who haven't?
Can you repeat the last part of that question?
Okay. The question was, is it true that female who have undergone FGM tend to give more pleasure to their men than those who haven't?
I don't think we have any evidence for male pleasure following a woman's FGM, so I wouldn't know the answer to that.
Thank you. I think we ran out of time. Thank you for coming. Thank you very much. We really appreciate the information you gave.
Yeah, definitely. Thank you, everyone. Thanks to the organisers for organising the webinar, and thank you for everyone. Thank you to the presenters. Thank you for taking the time to prepare your presentations. Thank you everybody who got involved and asked questions, and thank you to all who answered the questions. I've really enjoyed being part of this webinar. But that's it for today, guys. Thank you very much.
Thank you so much.
Thank you.
Thank you.
Bye.
Bye.